Welcome to Pathology Peoples. The topic is Acute Lymphoblastic Leukemia, Pathology in Depth. If you like the people, kindly subscribe the channel for more such peoples. Starting with epidemiology, it is the most common childhood cancer. Peak incidence seen in less than 6 years of child, more common in male as compared to female, and survival is more than 80% with good treatment. It is a ALL. It affects little lives. We can remember by this trick. Now moving on to the two main subtype based on a lymphoid lineage, BALL and TALL. So, according to TALL and BALL, TALL is most common in adolescents than children, and male female is almost equal, while BALL it has a second lower incident peak in adult more than 65 years of age. Now, moving on to the clinical features. So, BALL is most commonly seen in bone marrow. It affects bone marrow, so there is bone marrow failure, anemia, infection, and bleeding, while hepatosplenomegaly and lymphadenopathy is seen, and also CNS involvement characterized by headache, vomiting, and nerve pulses. Now, T, we can remember by T for thymus. So, it is mostly present as a thymic enlargement or pleural effusion, and most commonly present with anterior mediastinal mass with superior vena cava syndrome. Pathogenesis is there is a failure of lymphoid precursor to mature. Key mutations are T1221 and T922 and hyperdiploidy. Prognosis depends on cytogenetics. Now, peripheral smear shows the blast with medium to large size, scanty cytoplasm, coarse chromatin, inconspicuous nucleoli. So, we can differentiate between myeloblast and lymphoblast by this characteristic feature. So in lymphoblast, there is a size is smaller, scanty cytoplasm, or rod is absent with coarse chromatin and indistinct nucleoli. While in myeloblast, fine nuclear chromatin and prominent 1 to 4 nucleoli. Lymphoblast is present in ALL. There is also the handle is formed by the cytoplasmic projection seen in ALL. Moving on to the investigation, WBC will be 50,000 to 1 lakh variable with presence of more than 20% blast and smear showing lymphoblast. Bone marrow is showing more than 20% of blast. Now moving on to the classification, there is two classification. FAB classification and WHO classification. In FAB classification, there is L1, L2 and L3 blasts. L1 blasts are small uniform cells, nuclei are regular with condensed chromatin, inconspicuous nuclei, and scant cytoplasm. While L2 blasts are large heterogeneous cell population, nuclei are irregular, clefting with regular nuclei and fine chromatin and 1 to 2 nucleoli. There is a moderate to abundant vacuolated cytoplasm. So it is the L1, L2 and L3 blasts. Now moving on to the WHO classification. WHO classification of hematolymphoid neoplasm 2022. It is a 5th edition. So there is a previous 4th edition which is published on a 2016. Now this table shows the main differences between the 4th and 5th edition. So high hyperdiploidy term is introduced while BCR-ABL1 fusion is introduced. You can revise this table before the exam for more MCQ preparation. Another one differences are KMT2A rearrangement, ETV RunX1 fusion, TC3 PBX1 fusion, and B lymphocytic leukemia with TCF3 HLF fusion. So there is a two new entity included which is not previously included are BALL ETV6 with RunX1 like features and BALL with TCF3 HLF fusion. And another one is NOS categories introduced and one entity is deleted which is NK lymphoblastic leukemia lymphoma. So these are the main key features of the 5th edition of the WHO hematolymphoid lymphoma and BALL and TALL leukemia. Now moving on to the cytochemistry. So mainly lymphoblasts are negative for MPO myeloperoxidase because myeloperoxidase stain the granules. So there is no granules. If granules is very scanty, then it may stain light gray with Sudan black B SBB. But there is a pass positivity which is block like positivity. The second image shows the block like positivity. It is characteristic of ALL and there will be NSE negative, it is a non-specific asteroid. So blasts are MPO negative, NSE negative, while PAS showing block-like positivity. So it is main feature to differentiate between myeloblast and lymphoblast. The image showing block positivity of the lymphoblast. It's showing the scanty cytoplasm and large to medium size blast. Now moving on to the IHC immunohistochemistry, it is a gold standard. So BALL, it's stained positive for CD19, CD29A, CD22, CD24, TDT, CD34, HLA, DR, CD10 and PAX5, while TALL typically stained positive for TDT, CD34, CD99 and CD1A. CD3 and CD7 most commonly positive. It is a negative for myeloperoxidase and lysozyme. So ALL, BALL and TALL, it's stained positive for premature markers which are TDT and CD34. So as a ALL, it is a clonal proliferation of the premature cells. So this will be positive in a ALL. So we can differentiate from Burkitt lymphoma, which is a mature. Now moving on to the treatment part, there is 3 phases: induction, consolidation and maintenance. CNS prophylaxis is mandatory and targeted therapies are imatinib for Philadelphia chromosome positive. And for high-risk cases, there is a stem cell transplantation is used. Now prognosis. For prognosis, good prognosis is whenever patient is aged between 2 to 10 years, low WBC, hyperdiploidy and T1221 mutation. While for poor prognosis, we can remember by trick PKCS, it is a poor kids can't survive. So P for Philadelphia chromosome, which is T922, K for kids less than 1 or more than 10 years, C for CNA disease, and S for super high WBC count. These all parameters have poorer prognosis. Moving on to the quick recap. So it is most common childhood cancer. There is a risk factor of Down syndrome, radiation, EBV in infancy, infection, lymphadenopathy, and treatment is vincristine and anthracycline. So good prognosis is associated with T1221 mutation and bad prognosis is associated with T922, which is Philadelphia chromosome. Now quiz, which marker is seen in BALL? CD3, CD19, CD7 or CD34? Kindly comment the correct answer. That's all about the ALL. Subscribe for more pathology peoples. Happy learning. All the